Good morning, everyone. Looks like it's 7 o'clock here, so we'll get things going. Topic today is coagulation and cirrhosis. And I'm Brendan Lett, one of the anesthesiologists in Saskatoon. So our objectives today, we're going to review a bit of coagulation physiology and the changes that occur in cirrhosis. We're going to look at some available and appropriate testing options and cover best practice guidelines for coagulopathy management and cirrhosis. Start things off, just a little case study. 48-year-old male with alcoholic cirrhosis, child Pew class C, and esophageal varices. Booked for a TIPS procedure and presenting with an INR of 2.2 and platelets of 48. So I just want you to think, how would you optimize this patient prior to the procedure? Would you transfuse platelets or plasma? And if not, what would your transfusion thresholds be? So if you don't have a definitive answer in mind, that's okay. I wouldn't have either prior to making this talk. So a little bit of background in physiology, the role of liver in hemostasis. The liver is responsible for most of the body's hemostatic factors, aside from factor VIII and von Willebrand factor, which are produced in endothelial tissues. It is also responsible for the storage and metabolism of vitamin K, production of thrombopoietin to drive platelet production, atom TS13, which is a protein responsible for breaking down von Willebrand factor multimers, and finally, the liver handles most of the body's clearance of activated factors. Coagulation disorders are an integral component of liver disease and constitute a key aspect of most prognostic scores. For many years, bleeding issues have been the dominant concern amongst clinicians, but more recently, inappropriate clotting has taken the spotlight. Bleeding can be broadly divided into two main categories. Portal pressure driven. This has little relevance to hemostatic mechanisms. In other words, portal pressures increase variceal bleeding. And the second category would be mucosal or puncture wound bleeding, which may have a component of premature clot breakdown in cirrhosis. However, a more common clinical issue is likely inappropriate clotting, which is seen in portal vein thrombosis and mesenteric vein thrombosis, as well as peripheral limb deep vein thrombosis. This hypercoagulability can also contribute to accelerated liver atrophy through microthrombosis. Thrombocytopenia is probably the most common finding, and platelet dysfunction has also been described. But these anticoagulant changes are significantly offset by increased endothelial-derived von Willebrand factor. Factors 5, 7, and 10 are decreased, which causes prolongation of the prothrombin time, but clinically, that effect is significantly offset by diminished liver-derived anticoagulation factors, especially protein C. In fact, elevated endothelial-derived factor VIII, coupled with low protein C, contributes to a relatively hypercoagulable state. These changes, together with relative venous stasis and endothelial injury, make up the complete Virchow's triad and contribute to the common development of PVT and occasional DVT in cirrhotic patients. So in short, hemostatic pathways in cirrhosis are mostly rebalanced. Generally, that balance remains functional, but it's regarded as very precarious as it is significantly influenced by other factors, such as volume status, systemic infection, and renal function. As such, it is very difficult with current available testing to determine which way the scales are tilted, or if they still remain in balance. So this study used a thrombin generation test to investigate coagulation function in patients with cirrhosis with and without added thrombomodulin. So thrombomodulin, as I'm sure everyone recalls from the Royal College exam, is an endothelial protein that functions as a cofactor in the thrombin-induced activation of protein C by forming a bond with thrombin. So that raises the speed of protein C activation by about 2,000-fold. Conventional coagulation studies don't account for the effect of thrombomodulin or protein C. So if you're wondering what ETP stands for, that's endogenous thrombin potential. This graph shows that thrombin generation measured without thrombomodulin was impaired in this study, which would be consistent with the reduced levels of procoagulant factors in liver disease. However, when the test was modified by adding thrombomodulin, patients with cirrhosis generated just as much thrombin as the control group. Thus, the reduction of procoagulant factors in patients with cirrhosis is almost completely offset by the reduction of anticoagulant factors, leaving the coagulation balance unaltered. As such, the investigators concluded that the generation of thrombin is likely normal in cirrhosis. So how do we evaluate a patient's coagulation status then? And maybe more importantly, how should we not evaluate it? So all currently available lab measures of hemostasis have significant limitations in liver disease and lack adequate prospective data when evaluating bleeding risk. This is especially true when used as pre-procedure bleeding risk tools. No test accounts for variables such as volume status, portal pressures and flow, renal function, or endothelial dysfunction. And just to be clear, these tests are very useful in prognostication of liver disease, but you will see that they are almost completely useless in assessing an individual's bleeding risk. We'll start with the big one, INR. INR was originally developed in the early 1980s for standardization of therapeutic anticoagulation with vitamin K antagonists. It is unfortunately the most problematic test in coagulation in cirrhotics. So the test is a mathematical manipulation of the prothrombin time and measures only procoagulant factors, as we talked about. So factors 1, 2, 5, 7, and 10, but has no way of measuring anticoagulant factors such as protein C. To further devalue its use, the test is normalized against warfarin-treated patients based on the activity of a synthetic thromboplastin reagent. So each hospital uses a different thromboplastin reagent, and there's significant variation in the INR than in cirrhotics between different hospitals even, depending on which thromboplastin agent is used. So despite its shortcomings, the INR remains in widespread use for identifying bleeding risk, perhaps because of its availability, the lack of an established alternative, and a misunderstanding of its meaning. There are numerous published studies affirming the lack of utility of INR in predicting procedural bleeding in liver disease in a wide range of procedures. So it's been shown to be not helpful at all in liver biopsy, therapeutic paracentesis, colonoscopy with polypectomy, percutaneous endoscopic gastrostomy, dental extractions, bronchoscopy, renal biopsies, central venous catheter placements, arteriographies, and coronary artery catheterizations. It is also well documented that when clinicians attempt to correct the INR by using fresh frozen plasma before procedures, inadequate doses of FFP are given to achieve their INR goals, which are arbitrary to begin with. The American Association of the Study of Liver Diseases practice guidelines for the performance of liver biopsy states that there is no specific INR level that clearly predicts bleeding during or after liver biopsy. In this study, liver bleeding was measured after liver biopsy had been performed by a laparoscopy in 200 consecutive patients. Liver bleeding time was then analyzed in relation to prothrombin time, platelet count, whole blood clot time, and liver histopathology. This chart shows liver bleeding time compared to prothrombin time and the complete lack of correlation, even in prothrombin times as low as 10% of normal. This chart shows, again, no correlation between liver bleeding time and platelet count, despite a wide range of platelet counts. The authors concluded that there was no correlation or statistical significance between liver bleeding time and any of the indices of coagulation or severity of underlying liver disease. These patients were generally representative of a sick hospital population and included several with prothrombin activity as low as 10% of normal and platelets as low as 30. Therefore, it may be concluded from this study that measures of peripheral coagulation status are unreliable guides for the evaluation of the risk of bleeding after liver biopsy and of limited value in determining the contraindications for this procedure. So thrombocytopenia in cirrhosis is multifactorial, involving shortened platelet survival, decreased thrombopoietin production, platelet sequestration, and inadequate bone marrow response to thrombocytopenia. Platelet level manipulation, though, has historically been the other target of traditional teaching. Sorry, 1 second. So platelet level manipulation has historically been the other target of traditional teaching in bleeding risk management. Most retrospective and in vitro studies regard platelet levels in the 50 to 80 range as promoting thrombin generation, and over the years that has become standard of care. However, elevated von Willebrand factor and platelet sequestration and cirrhosis are mitigating conditions that have not been taken into consideration in this population. So this study looked at the distribution of human platelets in the body with radio-labeled platelets and circulation scanning in 3 different groups. They compared healthy controls, asymptomatic patients, and patients with splenomegaly. They also looked at the effects of epinephrine stimulation on platelet counts. Normally, about 1/3 of the total platelet mass is concentrated in the spleen and continuously exchanges with the remaining 2/3 of platelets in the vascular system. But in splenomegaly, the splenic platelet pool may be greatly increased so that 50 to 90% of total platelets are in the spleen at any given time. This redistribution of cells from the peripheral circulation to the spleen appears sufficient to produce thrombocytopenia even in patients with normal platelet production. So even though they test as thrombocytopenic, patients may have normal total body platelet mass. This, of course, is in the absence of liver disease, which likely does decrease the total body store of platelets. So results of the study are shown here, with the control on the left and patients with splenomegaly on the right. The descending black dotted curve shows the percentage of platelets found in the bloodstream after autologous platelet injection. In the control group, 50 to 80% of platelets remained in the blood after injection, while 20 to 50% became sequestered in the spleen. However, in the splenomegaly population, only about 15 to 30% of the platelets were found in blood, while 70 to 90% were sequestered in the spleen after just a few minutes. The investigators then took this another step and looked at the response to circulating platelet levels after a slow intravenous infusion of epinephrine of around 10 mics per minute. They found a steady increase in platelet levels following the infusion of epinephrine. They reached a peak after about 15 minutes. Platelet levels remained elevated as long as the infusion was continued and returned to baseline or slightly below within 10 to 15 minutes after the infusion was stopped. It is more likely that similar redistribution of platelets occurs after endogenous release of epinephrine in response to a major stressor, such as an invasive procedure or bleeding. Thus, peripheral platelet counts do not represent the actual number of platelets available at the time of a hemostatic challenge. And furthermore, achieving the platelet counts recommended by many guidelines is often difficult or impossible, when as little as 10% of transfused platelets remain in the peripheral circulation of patients with splenomegaly. So poor post-transfusion platelet counts would typically then result in repeat transfusions, leading to excessive intravascular volume, which will increase portal pressures, and those increased portal pressures will increase bleeding risk. And additionally, this may needlessly delay invasive procedures while chasing a platelet count. In this prospective case study, 852 procedures were carried out in 363 cirrhotics. Infusion of platelets and or FFP only marginally improved circulating platelet counts and INR values, as you'd expect by this point. 10 post-procedural bleeds occurred in the entire case studies, or 1 in every 85 procedures. Post-procedural bleeding was completely unrelated to the platelet counts or to the degree of INR abnormalities, also unrelated to the Child-Pugh classes. But bleeding was more frequent in patients who underwent multiple investigations or procedures. So in the 10 patients with the most profound alterations in platelets and INR, no post-procedural bleeding was noticed. The investigators concluded that in cirrhotic patients with low platelets and abnormal INR values undergoing invasive procedures, post-procedural bleeding is rare and unpredicted by platelet counts or abnormal INRs. In particular, the recommendation to infuse platelets when counts are less than 50 is not substantiated by this case series. So another reason cirrhotics do not need normal levels of circulating platelets is because of the highly elevated von Willebrand factor levels in plasma. This very well-designed study looked at von Willebrand factor antigen and von Willebrand factor ristocetin cofactor activity, assays in healthy and cirrhotic patients. In short, they found that cirrhotics had significantly elevated levels of von Willebrand antigen as well as ristocetin cofactor levels. They did note that there was a decreased ratio of the ristocetin to antigen levels and a reduced collagen binding capacity of von Willebrand factor in patients with cirrhosis. So in other words, they found highly elevated levels of von Willebrand factor, which were strongly related and correlated to the severity of the disease. However, the functional capacity of the von Willebrand factor also decreased relative to the severity of the disease. So then they isolated platelets and plasma from healthy controls and cirrhotic patients and mixed them in various combinations to see how they would clot. So as shown in this figure, the adherence of all platelets was significantly higher when platelets were resuspended in plasma from patients with cirrhosis, as compared with resuspension of platelets in normal plasma. So that's kind of confusing, but also this suggests basically that the quantitative increase in von Willebrand in cirrhosis outweighs any qualitative defects. And the elevated levels of von Willebrand will compensate for any qualitative and quantitative platelet defects as well. So highly elevated levels of von Willebrand, despite the fact that they aren't as effective, are enough to offset any decrease in functional capacity. Fibrinogen levels is the other thing we'll look at. They're an indirect marker of clot-making capacity, or rapid clot breakdown. However, reports of adequate fibrinogen levels in cirrhosis patients are variable, and there appears to be no clear relationship to fibrinogen levels and bleeding in liver disease. Fibrinogen is also an acute phase reactant, and levels can fluctuate quite significantly. So any assumptions we make about adequate fibrinogen levels come from trauma and congenital hypofibrinogenemia literature. We will come back to some recommendations on fibrinogen testing and management later in this talk. So one other test that is potentially helpful is thromboelastography, or TAG. So TAG provides a more comprehensive coagulation assessment than any of the previously mentioned routine tests, and its use may avoid unnecessary blood product transfusions in patients with cirrhosis undergoing invasive procedures. In this study, 60 patients were randomly assigned to a TAG-guided transfusion strategy, or that center's standard of care. Endpoints were blood product use and bleeding complications. As per that center's protocols, all of the subjects in the standard of care group received blood product transfusion, based purely on INR and platelet counts, versus only 5 patients in the TAG group. So 100% in the standard of care group versus 16% in the TAG group. Post-procedure bleeding occurred in only 1 patient in the entire trial, which happened to be in the standard of care group, and that was after a large volume paracentesis. So these authors concluded that in patients with cirrhosis and significant coagulopathy before invasive procedures, a TAG-guided transfusion strategy does lead to a significantly lower use of blood products compared to a standard of care transfusion, guided by INR and platelet count. They also found no increase in bleeding complications. Even in patients with significant coagulopathy, post-procedure bleeding was exceedingly rare, indicating that TAG thresholds may have been too conservative in this study and need to be reevaluated. In summary of TAG, although it's definitely more physiologic than conventional testing, we don't really have any well-defined parameters in cirrhosis patients, and so it requires subjective interpretation on a case-by-case basis, but probably is helpful. So in summary of our coagulation tests, the most consistent finding across all of the literature has been the demonstration of intact clotting mechanisms in cirrhosis, despite abnormal conventional indices. There is virtually no utility in using platelet count or INR to assess bleeding risk. TAG and possibly fibrinogen may offer better guidance, but assessment and prophylactic measures need to be individualized, preferably with multidisciplinary management. Importantly, your decision to proceed with procedures should not be solely based on any coagulation test, but rather on the severity of comorbidities of the patient and the urgency of the procedure. I'm not going to go into too much detail in VTE management, but I just wanted to touch a little bit, just in case you're not quite convinced that cirrhosis is actually a hypercoagulable state. So this was a systemic review and meta-analysis evaluating the risk of venous thromboembolism associated with cirrhosis. They found a significantly higher likelihood of VTE events in patients with cirrhosis, and that had an odds ratio of 1.7 and a confidence interval of 1.3 to 2.2. In these practice guidelines and literature review released by the American Gastroenterology Association in 2019, they also found an increased risk of venous thromboembolism in patients with cirrhosis. They also noted that despite this increased risk, prophylactic anticoagulation for VTE in hospitalized cirrhotics was significantly lower than non-cirrhotics, most likely due to their abnormal lab testing. So they also found no evidence that prophylactic anticoagulation is associated with any increased risk for bleeding complications. This is another systematic review. It looked at patients with cirrhosis and portal vein thrombosis who received anticoagulant therapy and evaluated its effects on recanalization and progression of thrombosis. Results of their analysis showed that 33% of patients without anticoagulation therapy had complete recanalization of the site of portal venous thrombosis versus 53% of anticoagulant treated. Here, only 9% of patients had progression of their portal vein thrombosis if they were anticoagulated versus 33% if they were not, which isn't that surprising. And this is probably more interesting that not only did they find no excess of major or minor bleeding in the anticoagulated group, only 2% of those who were fully anticoagulated had any sort of spontaneous variceal bleeding versus 12% in those with no treatment. So this lower bleeding risk is hypothesized to be due to anticoagulants decreasing the formation of microthrombi in the liver that would otherwise lead to the advancement of hepatic fibrosis and worsening of portal venous hypertension. So once again, variceal bleeding is pressure-driven, not coagulopathy-driven. Although prospective randomized controlled trials are generally lacking, both prophylactic anticoagulation for peripheral DVT in hospitalized cirrhosis patients and full-dose anticoagulation in cirrhotic patients is certainly indicated. With these things in mind, how do we put into practice evidence-based management of cirrhotic patients coming for invasive procedures? To start with, there are several common procedures that do not require any coagulation assessment, according to the American Association for the Study of Liver Diseases. These things that don't require assessment include paracentesis, thoracentesis, upper endoscopy for screening or banding of esophageal varices, as well as diagnostic colonoscopy with or without polypectomy. Their guidelines also support the low risk of bleeding, even in patients with a combined elevation in INR and thrombocytopenia. In almost all cases, prophylactic transfusion is not warranted. We'll cover this more in a bit. If you decide you must test to assess bleeding risk prior to a procedure, platelet count and fibrinogen level would be considered standard of care with recognition of their major limitations. Within these limitations, it is clear that assessment and prophylactic measures need to be individualized. The most important point to be considered is to avoid any prophylactic measures which offer only risk without benefit. If you're wondering why we need to be so cautious with what tests we are ordering and potentially basing our treatments, it's because the harm from inappropriate transfusion, especially in patients with cirrhosis, can far outweigh any benefit, and many physicians have a hard time doing nothing when they see numbers they don't like. So blood transfusions can be life-saving, but the risk of exacerbating portal hypertension from the subsequent volume expansion, as well as the risk of bacterial and viral contamination, immunologic complications, and cost, make it imperative to restrict their use whenever possible. There is little to no relationship between variceal bleeding risk or any procedural bleeding risk for that matter, and the coagulopathy associated with cirrhosis. Attempting to correct abnormal lab values with transfusion, especially in the case of FFP, may paradoxically make bleeding worse by increasing intravascular volumes and portal pressures. So before transfusing, optimize the patient as best as possible. This may include managing active intra-abdominal infections, correcting uremia with dialysis in patients with renal dysfunction, or managing low hemoglobin with iron or EPO if indicated, and time permits. These two articles provide multidisciplinary evidence-based guidelines with a considerable degree of overlap, so they're the basis of most of the following transfusion recommendations you're going to hear. So we'll start with fibrinogen. Our current best practice guidelines suggest checking fibrinogen levels in all cirrhotic patients undergoing high-risk procedures. Unfortunately, there is no consensus regarding appropriate transfusion thresholds for fibrinogen in cirrhotic patients, so they've been extracted from studies evaluating congenital hypofibrinogenemia and trauma literature. There seems to be little hemostatic benefit when increasing fibrinogen levels to more than 100, and in massive hemorrhage, hemostatic defects arise with fibrinogen concentrations of less than 100. So that makes it easy. Consensus committees advocate maintaining a minimum fibrinogen concentration of around 100. That's milligrams per deciliter in expected or ongoing bleeding. Cryoprecipitate has previously been the mainstay of replenishing fibrinogen, but a better option now exists in fibrinogen concentrate. So this has the benefit of being low volume, not requiring any cross-match, as well as minimal risk of pathogen transmission, and it allows for very accurate dosing of fibrinogen. Vitamin K may be beneficial. It will likely take more than 12 hours to correct any hemostatic defect in vitamin K deficient patients, and typically you'll only notice a very minor impact on the proton time. If you got your mic unmuted, can you mute it, please? However, it can be effective prophylactically when patients have experienced prolonged antibiotic therapy, poor nutrition, or severe malabsorption. A dose of vitamin K administered either orally or IV should be given. Absent an improvement in INR with a 10 milligram dose, there is no benefit to repeated dosing. So this study enrolled 921 patients with severe acute upper GI bleeding and randomly assigned them to a restrictive transfusion strategy with a hemoglobin target of 70 and a liberal transfusion strategy with a hemoglobin target of 90. Randomization was stratified according to the presence or absence of liver cirrhosis. They found further bleeding occurred in 10% of the patients in the restrictive strategy group as compared to 16% of the patients in the liberal group. The probability of survival was significantly higher in the subgroup of patients with cirrhosis and child Pew class A or B disease. The hazard ratio there was 0.3, so significant reduction in your 6-week mortality. They didn't see the same reduction in mortality in child Pew class C disease. There was no difference in that group. Within the first 5 days, the portal pressure gradient increased significantly, though, in patients assigned to the liberal strategy group compared to those in the restrictive strategy group. So in regards to hemoglobin, when there is severe anemia, raising the hematocrit to 25% or hemoglobin to about 70 will likely improve the margination of platelets and hemostasis. Preferably, this is done with iron therapy and or EPO, if appropriate. Keep in mind, though, that the total volume, if you do need to transfuse, is approximately 250 to 300 mils per unit, and once again, that will adversely affect your portal pressures. As such, it's important to use only the smallest volume necessary to achieve a hemoglobin level of 70. So with fresh frozen plasma, this one, it is very, very clear that FFP is not beneficial in correcting virtually any cirrhosis-related coagulopathy, and because of its high volume, can make any portal pressure-related bleeding significantly worse. So to keep it simple, just don't use FFP in any patient with cirrhosis. You may remember how INR is a mostly useless test of coagulation status. Well, unfortunately, sometimes we have to work with the useless tests that we have. To be very clear, if a patient's INR is less than 2.5 or maybe even 3, FFP is absolutely never indicated. If a patient's INR is over 2.5, it is still not indicated, but if the procedure is high risk for bleeding or the patient is actively bleeding, then start with administration of vitamin K plus or minus fibrinogen, depending on the fibrinogen level. That is usually all that is necessary to correct any coagulopathy associated with an INR of greater than 2.5. Many of the studies that I looked at actually, or one of them even had INRs as high as 8, and they still identified normal coagulation. So INR is, again, a very poor test. So if you get to that point, and if and only if bleeding is still ongoing, and INR remains above 2.5 after the treatment with vitamin K and fibrinogen, then you may consider 10 mils per kilo of FFP. A caveat here is if you are in a massive transfusion situation, a whole blood transfusion strategy is still appropriate. With regard to platelet transfusions, we've looked at several reasons why the platelet count is not a good indicator of bleeding risk. Additionally, we'll look at a couple more studies that suggest harm from trying to increase platelet counts beyond the baseline of a patient with cirrhosis. This first study was a recent randomized controlled trial where the investigators used a thrombopoietin receptor agonist to increase platelet counts before elective invasive procedures. These have been approved by the FDA in the States but aren't available in Canada, and they are fraught with quite a few complications. In this study, both the control and the treatment groups started with a median platelet count of 40. The study was prematurely terminated due to a significantly increased incidence of thromboembolic events in the treatment group. The platelet counts did go significantly higher in the treatment group as well, up to 5 times higher. This suggests that attempting to increase platelet counts may actually place patients at an increased risk of thrombosis. Even more notably, though, the higher pre-procedure platelet counts achieved by the treatment group, again, did not improve bleeding outcomes relative to controls. This study is a little bit similar to the previous thrombin generation study we talked about. It looked at thrombin generation in cirrhotic patients with a median platelet count of, again, 40, who then received prophylactic platelet transfusions. They found that despite platelet counts of less than 50, the thrombin generation ability of patients was consistently within normal range before platelet transfusion. In fact, most patients exhibited endogenous thrombin potentials above normal limits despite their thrombocytopenia. When the platelets were transfused, there was only a minimal increase in endogenous thrombin generation potential. So collectively, these findings again provide further argument against the use of prophylactic platelet transfusions. As you would expect, consensus guidelines strongly discourage preoperative platelet transfusions strictly to achieve a given threshold. There is limited data for a safe minimum preoperative platelet count, but it's likely significantly lower than we think. Aggregately, there seems to be no increased procedural bleeding in patients with platelet counts greater than or equal to 30. Therefore, in patients with cirrhosis and splenomegaly who are scheduled to undergo high-risk procedures, do not use preoperative platelet transfusions to achieve a particular number, unless counts are less than 30. In that case, you may decide to transfuse 1 adult dose of platelets. Remember, though, that the peripheral count is unlikely to change significantly after transfusion of platelets due to splenic sequestration. Therefore, there's no benefit in rechecking platelet count after administration. As for antifibrinolytics, tranexamic acid is recommended, but only if bleeding occurs. It's not meant to be given prophylactically, given the potential hypercoagulable state in cirrhosis. So likely, it's possible it increases your risk of VTE. As for prothrombin complex concentrate, or beriplex, or octoplex, there is no data whatsoever that suggests a benefit of these concentrates in cirrhosis. Partly because dosing is based on INR, which isn't helpful, and partly because thrombin generation is already normal in cirrhosis. So PCCs may actually increase, again, the risk of thromboembolic events, and as such are not recommended for use in cirrhosis. Desmopressin can enhance platelet function, but only in the presence of uremia. So it lacks any physiological basis in patients with isolated liver disease. It may be appropriate for patients with end-stage renal disease who are uremic, but there is insufficient data to support its use in cirrhotic patients for routine prevention or treatment of bleeding. So getting back to our case from the start of the lecture, I would say that you could safely proceed with this procedure from a bleeding risk standpoint without any prophylactic interventions or any further investigations. To transfuse this patient prophylactically would increase the risk of harm with likely no benefit. In summary, remember that the coagulation cascade is rebalanced in cirrhosis and mobile state, as evidenced by the increased risk of thromboembolic events. Standard measures of coagulation, such as INR, offer no value in assessing bleeding risk to the clinician. Reliance on INR consistently results in overtreatment in attempting to correct lab values and underutilization of appropriate anticoagulation for patients admitted to the hospital. When assessing a patient's preoperative bleeding risk, one should ensure that, firstly, treatment would be necessary to prevent bleeding. An example might be a neurosurgery case versus a hernia repair. Remember, many procedures do not require routine evaluation simply because of the presence of cirrhosis. And secondly, when you do order testing, fibrinogen level and platelet levels are likely the most helpful thing you can order. Transfusions carry significant risk, especially in exacerbating portal hypertension, and are likely overutilized in patients with cirrhosis. And once again, FFP has no role in the management of coagulopathy in cirrhosis, and other blood products need to be used extremely sparingly. Further study is needed to look into global measures of coagulation, such as TAG, to determine appropriate cutoffs for therapeutic interventions. And that's the end of this lecture. If there's any questions, be happy to answer.